When you want something that is stable, when you put it on the ground, you use 3 legs. Unfortunately, dentistry is a bit like this sort of table. Okay? You are trying to get 8 legs or many legs to touch the ground perfectly at the same time. In fact, it's worse than that, because dentistry is about trying to get a table with 16 legs. Yes, the 3rd molars are gone, but you have 2 legs on your table that are the condyles. And not only are they legs, but they're like legs with wheels that roll up and down ramps. So that is the sort of table that you're trying to balance. You're trying to get all of those things with equal pressure at the same time. Now, if you've ever tried to balance a table, you know what we do. We get the teaspoon and we jam it underneath the one leg that is allowing the table to rock. Or we roll up a napkin and we put it underneath. And that's something I want you to keep in mind as we talk about some of the cases later. Because what do you do when you have a wobbly table? When you want to fix it very quickly, you don't cut the other 3 legs down. Quite often you just build 1 leg up. Okay? And that's actually quite important for when you're adjusting bites, because a lot of the times we're trained to be reductive with our adjustments, to cut teeth down to get everything to fit, and it's often faster to build things up. So sometimes when I'm adjusting occlusions, I will, there are times where I will do little tiny fillings for free on all maybe 8 or 9 or 10 teeth to lift them up so that we get a level occlusal plane, because that is faster than sitting there tapping carbon paper and grinding teeth down and grinding and grinding and grinding and grinding and grinding. So that is occlusion. We want to make our many-legged table stable. That's all we need to do. Of course, like anything that is simple, it is not necessarily easy. In fact, almost nothing that's simple is easy. So things are simple, they're not easy. So what we'll do is we'll start with something that everyone does every day in their dental career, which is what I call the bracketed tooth. That is a single tooth that has a tooth on either side of it. And this is the most common type of occlusal thing you will ever do. And if your tooth on either side is stable and you're getting nice vertical contacts, then you really don't, all you need to do is make sure that there's nothing high. So a tooth like this, it's a difficult filling, okay, from a restorative point of view, but from an occlusal point of view, very straightforward. So we go through, we'll do gingivectomy just so that we can get our matrix in, we'll get isolation, all the usual steps of doing restorative dentistry, and obviously the isolation and because it's so subgingival, it's a difficult from a restorative point of view, but from an occlusal point of view, it's very straightforward. There are some things though that can make your life faster, even for a simple thing like this. So there's 2 main spots where it can be high. And really when we're doing the single tooth, the bracketed tooth, the only thing we're worried about is that the tooth is not high. That when the patient bites together, in fact, I don't even care if the tooth is slightly low, because in most cases it will supererupt if it's low and it will come back into contact anyway. But I definitely don't want it high, because with composite resin, what happens when it's high? The patient will complain or it will break. So if you leave a composite resin restoration or any sort of direct restoration high, there's a chance of sensitivity, there's a chance of pain, there's a chance of tenderness, or just annoying the patient, and there's also the chance that it will break very quickly. So far more quickly than it should be. So there's really 3 areas that we're going to have to adjust. And the first one is marginal ridges. Now, when I started, I had no idea about marginal ridges. I would just make the marginal ridge as high as anything, like 3-4 millimeters higher than the adjacent tooth. And then I would grind it down very slowly. Now, over time I learned it's far faster when you're doing the marginal ridge to actually look at the adjacent tooth. And either when you're shaping the restoration, trim it so that it's the same height, or when you start adjusting, because that takes a fair bit of experience to be able to trim a marginal ridge with your instruments so that the composite resin is the right height when you start, assuming that you're not using a laboratory-made restoration. But when you start the adjustment, before you sit there and start getting the patient to chomp up and down on carbon paper, just look at the adjacent marginal ridge and get a big burr and cut it down to that height before you even try. There's no point putting carbon paper in and getting the patient to chomp up and down when it's so massively high. They're going to be jacked up like crazy. So the marginal ridge is the first one. The second one is you've got cusps and you've got fissures. Which one is worse to adjust, cusps or fissures? Any ideas? Fissures, yes, that's right. Okay, because cusps, trimming the top off a pointy thing is always easier than trimming the valley deeper. Okay, so I always want to have my valleys as deep as possible from shaping the resin first, and I want the patient biting on the ridges or the cusp because they are very fast to adjust. Now, in this case, I've actually just shaped the resin so that it has a really deep fissure pattern. If you're not, if you don't have the time to do that sort of thing, or you're just not interested in shaping your resins, then what we're going to do is we're going to do a different style of adjustment to most, okay, which we'll go into in a moment. The key part is, okay, my jaws get better as we go along. Okay, this is a very, very simple jaw. We've got to start really simple. Okay, so simple jaw. The key is we've got to think about what's happening. So we open up, the jaw opens, okay, and then we're going to make a filling that's too high. It's almost always that our fillings are going to be slightly high unless you're an absolute genius. Now what's going to happen is that we are going to have a look at how far, when they bite back together, we're going to have a look to see how far apart the teeth are, and then we're going to do a thing called considered occlusal adjustment rather than grind in hope. So grind in hope is where you don't look at anything, you just put the carbon paper in and you go tap together and then you grind a bit and you put it in, tap together, grind a bit, and you keep doing this again and again and again, and after 15 minutes you're still sitting there grinding on the fissures, and it's super tedious. That's the main reason why I shape fissures, because it's so boring sitting there grinding composite resin down. But an alternative method is that we actually look and go, now the front teeth are sitting 3 millimeters apart and they were touching at the start. We know that 3 millimeters on the front is probably 1 to 1.5 millimeters on the back. So just grind 1.5 millimeters off. Don't do like tiny little tinkers. Okay, it's a bit like when we learnt to prep at dental school. They would say, okay, prep 2 millimeters deep, and you prep, you know, 1/4 millimeter, and go, is that 2 millimeters yet? And no, it obviously isn't. That's the difference between dental millimeters and real millimeters. So if you see that the teeth are 3 millimeters apart, just grind down that much and then check again.